This Brew and Brilliance episode discusses the topic of suicide. In this episode, we will be following the Samaritans guidelines on media discussions on this topic. Hello, and welcome to Brew and Brilliance, a podcast where we talk to academics from across the university who are involved with the Healthy Ageing and Chronic Conditions Research Institute. We will be speaking to researchers who are leading innovative interdisciplinary approaches to promote lifelong health, delivering improved interventions to manage chronic conditions more efficiently. These sessions are essentially opportunities for us within the Healthy Ageing and Chronic Conditions Research Institute to meet colleagues from across and beyond our faculty to foster knowledge sharing, collaboration and networking. My name is Adrienne Cleverly, and today I'm joined by Professor Anne John. Anne is a Professor of Public Health and Psychiatry at Swansea University Medical School, with a background in public health and general practice. Her research focuses on suicide prevention and self-harm, particularly among children and young people. Anne is the Director of the National Centre for Self-Harm and Suicide Prevention and the Principal Investigator and Co-Director of DataMind and the MRC-funded Health Data Research UK Mental Data Hub. Anne is strongly committed to using data-driven insights to develop effective prevention strategies and inform policy, working closely with people with lived experience to ensure that research has real-world impact. Her commitment to translating evidence into meaningful policy and practice is at the heart of her work. So welcome and thank you for joining us.
Thank you for inviting me.
So you've got a lot going on with your research and everything. Can you just give us a little bit of a background about your research journey and what sort of drew you into research in suicide and mental prevention and mental health?
So I started off clinically. So I was working as a general practitioner after having done jobs in psychiatry and accident and emergency. And after a bit, I sort of thought, I'm really putting a sticking plaster on the people that I'm working with. It's sort of like, it comes down to that classic public health thing.
Yeah.
Really, it's the causes of the causes that need to be addressed.
Yeah.
And so I moved into public health and I did my public health training. I became a consultant in public health. And then I realised, because I never thought I'd become an academic, that I could actually do analysis. I could do epidemiology. So I came to the university to do my doctorate and I realised that, SAIL, which is like a data bank of health and social care data at Swansea University, was just sort of coming into being. And I realised that real world evidence really speaks to policymakers and change makers. And so you could do that work and make the changes. So I often say to my team, we're not saying anything that most practitioners would say, but we can show it in the data and that speaks to people. And I think the thing about mental health and suicide and self-harm is that they underlie, whether it's sort of being involved in the causation of problems or as a result of a myriad of problems. They're there for everyone. And addressing those issues were really important to me and the people I was seeing in front of me. So, you would see children whose lives made it really difficult for them to manage their emotions, and that could set them on trajectories. And if you can get intervention for those children, interventions that work for those children early enough in their lives, you can make a real difference.
And it's really interesting, that sort of way you described it with sticking a Band-Aid on somebody, because you'll see the same people, dipping in and out of health services, and it's just like you say, putting a dressing on and moving on. So your background really has sort of, would you say it's shaped where you've moved with your research? Or
Oh, absolutely. And I think it's like so for whatever reason, whether it was because I was a woman or because I was interested, or a combination of both. Throughout my career, I would often be seeing people, with mental health problems, or with mental health problems associated with physical health problems. And I think I always wanted to be able to address those issues in my work.
Yeah.
And it sort of became, basically now there's people talk about mental health a lot.
Yeah.
And there's, I think literacy has improved. I think stigma is still there, particularly for suicide and self-harm. But back then, people weren't talking about it. You weren't getting research funding for it. But those of us in the field knew how important it was. So I felt that I used to spend a lot of my time going, and what about mental health? And what about mental health? And what about self-harm?
Yeah. And it's those sort of things, that the narratives around it, that really does sort of shape the direction. Because some of the narratives you've looked at have been specifically around males as well, hasn't it? And can you just talk us a little bit around some of that? Or
So we know that men don't go to see their GP as much as women.
Yeah.
And that's for all sorts of reasons. And so the general consensus was that when men are in distress or have mental health problems, particularly if they don't have a partner who's encouraging them to go, they don't seek help. And that's combined with, stigma, with all the ideas around, masculinity and strength, all those things. But we did a piece of work where we looked at people's healthcare contacts in the year before they died by suicide. And it's really important to say that, the vast majority of people who die by suicide haven't been in contact with mental health services. It's about 28% have.
wow.
Many are in contact with primary care. And what we found was that for men and women, contacts with healthcare services increased the closer you got to their death.
Oh my gosh.
So what we changed the narrative about was that men don't seek help. They actually do seek help. And then we did another piece of work looking at young people and self-harm. And what we found in that piece of work was, at the time, there's been new NICE guidance since, but at the time, NICE guidance was saying that if you were under 16 and you contacted the emergency department or were admitted with self-harm, you should stay overnight so that people could look at your life and formulate what were the issues in your life. So everyone should have been admitted. And what we found was that young women under 16, young girls, were much more likely to be admitted than boys. And at first I thought, maybe that's because of the methods that they're using to self-harm.
Yeah.
But we found it didn't matter what method was used. And so what that says to me is, maybe in health services, like in society, we respond to men in distress differently to how we respond to women.
Yeah.
And so we basically change that narrative around, yes, men need to seek help more, but equally we need to respond appropriately. And I think that takes the onus off men.
Yeah.
Because the onus was always like, well, the problem is you're not seeking enough help. And Samaritans then did a campaign that was not just open up. It was open up and then to all of us, listen up.
Yeah.
So I think, so that sort of data can really challenge how we, the things we think are common sense.
Yeah.
That may not always be strictly true.
And sometimes it's the knowing, isn't it? You don't necessarily know. So people might not necessarily know how to respond because they might have gone, yeah. And so some of these narratives that you've changed then, it's your public health background sort of really helped push that for change in policies?
I think I think what a public health background does, but also in general practice,
Yeah.
is it makes you see people in the context of their lives as opposed to their conditions.
Yeah.
And you realise how much those things impact all the contacts with health services are there. You know, one of the biggest things is poverty and deprivation, isn't
Yeah.
it? You know, access to healthcare services. You know, in suicide and self-harm, you know, the vast majority of people who self-harm don't seek help from health services. They talk to family and friends. They may disclose in school or at the Citizens Advice Bureau. So having a society that can respond without feeling uncomfortable, you know, there's lots of myths out there, like,
Yeah.
you know, if I talk to them about it, I'll plant the idea. Those things are not true. The evidence doesn't support them. So enabling people to have those conversations, respond when people send those signals is really important.
Because it's like if there is an opening for someone to respond, then there is a message in there, isn't there, you know? And it's like making sure you've got that. Sorry, to go back a little bit, you touched on some of the work with young children, and you've also got a lot around lived experiences.
Yes.
Are you able to tell us a bit about how that works?
So I think the thing about lived experience in suicide prevention and self-harm research, but also in mental health, is one, the recognition of how important those voices are.
Yeah.
You know, so I have not ever come out of a meeting with someone with lived experience without something I can do to improve a project.
Right, okay. Yeah.
And I think that's really important to understand that, because I think sometimes not all researchers are convinced. And then I think working with people with lived experience, it's really important in the field that I work in, it's really important to be flexible.
Yeah.
So be flexible about the way you work with people. So, you know, sometimes people might have a lot to give. Sometimes they won't. Sometimes they'll have their cameras on, sometimes off. The conversations won't always be easy.
Yeah.
You know, over the course of my career, I've had some really tricky conversations with people. But so long as you remain open and flexible to different perspectives, it's really important. And sometimes some of those conversations are about people coming from different perspectives. And once you develop that common understanding, then those conversations move forward. So I think there are people skills and openness that you need.
Yeah. Because the thing is as well, if you've said it immediately, you know, listen. It's one of the big things. And if someone is speaking to you about something that is and ultimately can have a huge impact on their life, you know, not just that period, but the longevity of it, you know, if there's right support and nobody's listening.
And I think it's like, you know, generally, you know, sometimes we ask people with lived experience to come and, you know, speak at conferences or work with us on papers. It's having that flexibility and making sure that everyone's benefiting.
Yeah. And on that note, one of the most recent things that you've been involved with is around education, and some of the projects that you sort of brought into the university. How did they emerge?
So I think, you know, going back to the beginning when I was sort of talking about young people's trajectories.
Yeah.
You know, so one of the things I often used to say when I was giving talks was, you know, I come to self-harm with the perspective of health. But the reality is that young people can come to the attention of criminal justice, or they might come to attention through education, or it might be health. And the impact of where they touch services is huge.
Yeah.
You know, if it's criminal justice, that has a massive impact. So working with young people and interrupting those trajectories, I think, is vital.
Yeah.
You know, it's absolutely where I want to be. And if you want to do that work, schools are a really important setting, but they're a really complex public health setting.
Yeah.
You know, when you try to do universal interventions in schools, and by universal, I mean, you know, where you're doing it to everyone, not just kids at high risk, you know, you can do harm.
Yeah.
You're not, you know, those sorts of interventions don't have big effect sizes. You know, you're not usually dealing with making a big difference. You're dealing with making a little difference to lots of young people. And those things can be tricky to measure in sort of traditional trials and things. So they're really important settings. And the work that we did, and I guess I was a school governor as well. So, you know, I've got 3 children.
Yeah.
So it felt like a setting that I had some understanding of. And what you would see is, you know, children who weren't in school, children who were excluded. There were lots of supports in place, but also in a system that was very much being measured by attendance and attainment. There's also difficulties. You know, all parents will remember those days of 100% attendance certificates. When actually the children who weren't in school, it was often because they had needs.
Yeah.
Or they were not brought, not because they're inherently, you know, naughty or wrong. And what we did was we took education data that's routinely collected about absence and exclusion, and we linked it to health data. And within that health data, we looked to see what were the levels of anxiety, depression, conduct disorders, neurodiversity, learning difficulties. And then we looked to see who had had a diagnosis for schizophrenia and bipolar disorder up to the age of 24.
Oh, wow.
And unsurprisingly to everyone, the levels of recorded diagnoses of all these things were much higher in children who weren't in school.
Yeah.
And then what you can take from that is actually poor absence and exclusion. Those children need support. That's why they're in those data sets. So it flips the narrative. And one of the things we argued for was that why don't you use that routinely collected data to flag young people that might be in need of support? And in Wales, it resulted in persistent absence.
Yeah.
You used to have to have been absent 20% of the time, and that changed to 10%, which means young people were being flagged much earlier. So I think that's sort of looking at how things can change without adding extra burden in a system is really important. And then COVID came along and, you know, everyone's focused on attendance now because we haven't returned.
No, because the attendance, but like that persistent attainment that you were talking about, there are so many external factors away from school, isn't it? Because a lot of the, I don't know, myths around it are, you know, they're not in school, you know, there must be an issue with school type of thing, but that's not necessarily the case, is it? It's the support externally and away from school, like you said, even getting to school.
There's so many factors. And I guess one of the things, so we've done a fair bit of work on that since.
Yeah.
You know, and it there really is a thing about working with families.
Yeah.
around attendance.
And has this work then, has there been any sort of changes in policy and practice around that because as a result of what you found? Or
So I think there was that change in definition of persistent absence. And then post-COVID, there's been a lot of work through Welsh Government. You know, there was a ministerial task force. There's a real focus around attendance. And we've been able to feed in the evidence that we have. There's also things around, you know, belonging, and having a sense of belonging in school improves attendance. Mentorship, working with families, these sorts of interventions. So we've been able to feed our evidence into thinking about policy change.
And how that impacts them beyond school.
Absolutely.
Because, you know, you're in school for a very small amount of time in the long term, aren't you? You know, but it has huge impacts on what that sort of means in your later life, if you will.
Absolutely.
But like you've talked about self-harm with children, primarily the issues around younger people. Do you have challenges around that in terms of children that self-harm from a young age? How does that look for them, like through their lifespan?
So self-harm can happen at any age.
Yeah.
For the highest rates are sort of in older adolescent females.
Right. Yeah.
The vast majority of young people, self-harm behaviours settle as they get older, but some people carry on. There are... So whereas about half of those who die by suicide have a history of self-harm, the vast majority of people who self-harm won't go on to take their own lives. I think the things that concern me, so we've recently, in England, they've published the Adult Psychiatric Morbidity Survey.
Yeah.
And what you see is that self-harm and suicide attempts have been increasing year on year since that survey started. And the reason that survey is so important is because, you know, I do a lot of work with contact with health services, but we know the vast majority of young people don't contact health services. So understanding what's going on in the population is really important. So we know it's a behaviour that is often a response to lots of things that are going on in young people's lives.
Yeah.
And we know that it's associated with sort of poorer life trajectories.
Yeah.
So I think it's really important the reason I do this work is I think, you know, self-harm is a really important signal that there are things going on in young people, but someone's life that we need to be addressing.
There's something there. And is that sort of what's behind the vision of this centre that you've got? And are you able to tell us about the centre?
So,
because this is exciting.
Yeah, so it's really exciting.
Yeah.
So I've been working in this field for a long time now, but last April, but we've been working on it before that, we launched a new strategy in Wales for suicide and self-harm prevention. And alongside that, Health and Care Research Wales put out a call for national centres, and we were funded. The centre launched last April.
Yeah.
And we're actually named in the strategy as the advisory body for the strategy to Welsh Government. And, you know, that's really exciting about making a real difference to the population of Wales in this field. And it also has resulted in funding. So we have set up a lived experience group with Samaritans who will advise on all the research going on in the centre. So I think, so it is really exciting.
Yeah.
It increases our capacity to do this work, to do research in this area, to make a difference.
Yeah.
It means that, those resources will be creating resources. I think within Wales, there's a team in the NHS performance and improvement part that leads on suicide and self-harm. There's a team in Welsh Government now that leads on the strategy. We've got the group with lived experience. I think there's a real sort of critical mass to make change, and there's real support from, politicians. We've got, the Minister for Mental Health, Cabinet Secretary for Education, and people in the Senedd, like Julie Morgan, who chairs the cross-party group, who are really passionate about this. I really think there's a critical mass of making change that's evidence-informed.
And that's one of the things I was going to say, because it's not like you've just gone, I know, it's really sort of been built up, hasn't it, from going to, looking at how things can change. And it's just such an incredible thing to have, but also to be a part of, I would imagine.
Absolutely. I love it.
On that note, are there any other exciting things that you've got going on for you at the moment?
So I think this year has been... So over the last year, I've been working with the British Standards Institute about a suicide prevention standard. So when they approached me, probably like you, I was like, BSI, don't they do like widgets and like all the standards for like equipment and things? But actually, I don't know if you remember, but like last year, a couple of years ago, there was all this stuff about menopause and about standards for menopause in workplaces, policies, all of that. That was following a BSI menopause standard.
Oh, wow.
Yeah, who knew?
No.
So they have such strong relationships with organisations and workplaces. The work they do makes a real difference.
Yeah.
So it's been a real pleasure to chair the overarching committee for the Suicide Prevention Standard. I also worked, this is 70 organisations from across sectors. There was a drafting panel. The BSI team was amazing. So we created the standard. It was launched at Speaker's House, I think a couple of weeks ago now. It may have been last week. It's been a very busy time.
They just merge into one for you at the moment.
And since it was published on November the 4th, it's been downloaded thousands of times across 60 countries.
Oh, wow.
And it's a real like step-by-step practical guide for organisations, be they big organisations or small, medium enterprises, to, put sort of prevention, intervention and support for those affected by suicide in the workplace.
Yeah.
So that's been really exciting. And then the second thing was the Royal Foundation, which is, delivers on all the work that sort of Prince William and Princess Catherine are focused on.
Yeah.
Prince William has, he's chosen suicide prevention as one of those areas he really wants to work on, and they've set up a national suicide prevention network that I'm chairing that's really focused around third sector organisations. So they've got a 4-nation approach, and in the field there's all the statutory services, but actually the third sector really does a lot of work on the ground with people.
Yeah.
And I think working across those organisations will, with the sort of power that Prince William brings in terms of changing narratives around topics, I think there's a real opportunity for change.
And that's kind of made us go full circle a little bit, isn't it? Because we were talking about how these changes can happen, and here you are, a lived experience of making changes.
So I'm really excited about these opportunities going forward.
They're incredible, and it just means better results for the people that it makes a difference to.
And keeping that evidence informed,
It's not
perspective.
It's not just someone thinking, oh, actually,
that might be a good idea.
Yeah, it's like you say, it's evidence informed, and it's making so many positive changes.
And because with self-harm and suicide prevention, there's rarely a single reason why someone takes their own life, which is why you need sectors to be working together. So I think these sorts of networks, organisations that work in sectors, that sectors listen to, these are the ways of making change. So it's been very exciting to be a part of it all.
I'm just grateful you're here to be able to share it with us, because it is so incredible and exciting, but so impactful.
Yes, I hope so.
Which is ultimately what we want in research.
And I think because I've come from a clinical background, impact is where I've always been focused, is making those changes in people's lives.
And things are moving in the right direction. Do you know what? It's been a genuine pleasure to hear about what you've got going on. And it's something so incredible. It's just, I would be proud if I was you.
Thank you.
It's a very interesting topic of conversation. Thank you so much for bringing it to us.
Thank you for having me.
Oh, it's genuinely been a pleasure. Can people reach out to you if they...
Of course.
Yeah, and you can also reach out to us at Swansea University. We are the Faculty of Medicine, Health and Life Science, and we are the Healthy Aging and Chronic Conditions Research Institute, but we've also got the wonderful Suicide and Prevention Mental Health as well. And genuinely, thank you so much.
No, thank you.